And we will be posting all of the recordings on YouTube and on our website. My name is Julia Reichel. I'm the co-chair of the Catskills Addiction Coalition. And this is James Anderson. James, tell us who you are.
Hi, folks. So I am a clinical psychologist working at Bassett. I'm also the medical director for Leatherstocking Collaborative Health Partners, which is our legacy organization coming out of our leadership of the Disrupt Project for this region. I have been...
Define Disrupt, because I bet...
Oh, yeah. Sorry about that. Good point. So Disrupt is alphabet soup, if nothing else. So it's delivery system, reform, incentive, payment. And this is a program that was put on by New York State amongst a number of other states from 2015 to 2020. Primary aim, so it was designed to engage in Medicaid reform to improve outcomes for patients, as well as reducing costs to taxpayers. And so that's sort of the major thrust. And then there were a number of clinical endeavors that kind of fell out under that. One of those areas broadly was impacting substance use disorders. And that's where this work that I'm going to talk about today first hatched.
Awesome. Thank you. And James is going to go into depth about what exactly this work entails, but it is sort of in a larger ecosystem of a harm reduction view of how to treat substance use disorder in people who use drugs.
Very much. And we're going to talk explicitly, and we can go through it quickly if it's going to be redundant for folks in here, but we're explicitly calling out harm reduction as part of this work. It does not work at all without that perspective.
Yeah, it's really a sea change. Just as a note, I moderated a forum with 3 local sheriffs this morning. Mm-hmm. I don't think we even said the words harm reduction, which we hope to, right? Because that it does help.
Yes.
So there's like a huge culture gap that we're trying to bridge here. Before we get started, again, this session will be evaluated. You can evaluate us on how we did, tell us feedback. I've put links to the evals at the top of the chat. I will post them again near the end. We have one last meeting happening today at 3 o'clock. There's a play, A Wing and a Prayer, about addiction, written by a Delaware County playwright, that's being performed. And then there will be a critical panel talking about addiction afterwards, which is awesome. Then that concludes our week, which is amazing. We've had a lot of sessions. I think that's basically it, except for ground rules about engagement. We do very much want you to engage if you feel comfortable doing so. Feel free to unmute, put your mic on, put stuff in the chat. That's no problem. 9-month-olds who are vocal are welcome. Abby, that's fine. This is really informal, and James and I are pretty chill with this kind of thing. And we really want you to get a feeling of connection and the fact that there's a community out here to help treat folks with dignity and respect with substance use disorder in our region. That's really the goal here. With that said, I think that's all my stuff. So I'm going to let James kick it off.
All right. Well, thank you, Julia. And thanks for coming, everybody. So I hope that this is engaging and interesting to folks out there. I'm going to talk about a project that we did to inject care for folks struggling with opioid use disorder into our primary care network, and the framework of harm reduction that is required to do that sort of work. And then I'm going to share some of our outcomes to date. I guess I'd like to encourage folks, if you are comfortable. I mean, I hope that we will have some discussion at the end of the presentation. But if there are questions or comments that come up as we go, I'm certainly happy to do my best to address those in real time. So with that, I think I'll just go ahead and get started. So as you can see here, I'm calling this presentation Project ECHO and Primary Care Buprenorphine Treatment for Opioid Use Disorder, implementation, and clinical outcomes. I am, as I mentioned, a psychologist at Bassett, and also work for the Leatherstocking Collaborative Health Partners. All right, can I advance? That's my first test. There we go. Okay. Well, I think we'll go fairly quickly through this one here because I think this is pretty well established right now. We're clearly living in a pandemic as I sit here in my basement office with my cat meowing outside the door, addressing you rather than talking to you in person. But even before our COVID pandemic hit, we were in the midst of an opioid epidemic. Just a couple of numbers there. Per SAMHSA, we know that there are over 1.5 million people at least that are struggling with opioid use disorder in the United States. And we estimate that the annual death toll is about 140,000 people. So that doesn't even take into account some of the additional costs, both monetary and in terms of lives that are affected with loss of work, loss of children, dollars spent on hospitalization, incarceration. So this is a real problem that affects individuals in society on a number of levels. I think we started to talk a little bit about DISRIP at the beginning here. So I came to New York in 2016 to take on leadership of behavioral health and addiction initiatives under the auspice of DISRIP. So like we mentioned, it is a state Medicaid reform project, and the various regional groups had the opportunity at the beginning of the project, this was before I came on board, to select from a number of clinical projects. And our group, Leatherstocking Collaborative Health Partners, with Bassett acting as the lead partner, chose, I won't bore you with the official name, but essentially chose trying to help folks struggling with addiction as one of our clinical goals. So I arrived and we kind of knew that we had this as a goal writ large. And we had to figure out how we were going to go about tackling the problem. We knew that opioid use disorder or opioid addiction was a significant problem for our country, for our state, and for our region. And we knew that there were not sufficient treatment. There was not sufficient treatment available for folks that were struggling with OUD. And we started to think about, okay, well, what can we do that is going to be effective and evidence-based, that is going to be accessible for our patients, and is going to be sustainable once the funding that is tied to DISRIP dries up. So I'm going to show you a couple of images here in a moment. We know from our review of the literature that if you want to offer care that has a strong evidence base, you should probably be including, I would take it a step further, putting at the front of that care treatment with medication if you want to have the most efficacy. And for a long time, the main treatment that people thought of when they thought of medication for opioid use disorder was methadone. Methadone has been and continues to be an effective option. I want to show you here, it might be obvious for you native New Yorkers. This is a map of New York City and the surrounding area. And the yellow pins that you see in the map here are methadone clinics that are associated in that area. And so if you live in that region of our state, methadone is a reasonable option for you. So just a word about the way that methadone is used and regulated in this country. It's regulated pretty tightly and probably appropriately so. It is a medication that can be helpful, but also has a higher risk profile. And therefore, the federal government has determined that it can only be administered at federally designated programs called OTPs, opioid treatment programs. And folks have to show up to obtain their medication from the OTP, typically have to show up daily in order to get their dose. So if you are in a densely populated area and you've got an OTP that is close to you, that can be a viable option. So this is a lay of the land of our region. So we had 5 counties that were associated with our district project. And let's see if I can name them all now. We had Madison, we had Delaware, we had Otsego, we had Shenango, and I'm missing one. Schoharie, I'm sorry. So those were our counties that were covered. And as we started our project, we initially had 3 clinics that raised their hand, 3 primary care clinics that raised their hand and said that they wanted to participate. And so I kind of used this to illustrate. The blue boxes there are those clinics. Again, the yellow pins are the closest methadone clinics in the area. And we mapped this out from each of those clinics. At its closest, it is a 45-minute one-way drive to one of those pins. And so it became evident to us that that was probably not going to fit with an effort to, I talk about it as about being a little bit greedy with our care. We want to help people avoid opioid use or reduce opioid use, but we want a lot more for them than that. We want them to be engaged in their lives. We want them to be interacting with their families and their kids. We want them to be able to work. And it's very difficult to do many of those things, specifically to work, if you have to be in your car every day, driving back and forth to a methadone clinic that is an hour away. So we thought of another medication that has a good deal of efficacy, known as Suboxone or buprenorphine. So it's been demonstrated in the literature for well over a decade now that Suboxone, or I'm going to use the generic term here throughout, but you can use these interchangeably, buprenorphine, is an effective treatment for opioid use disorder, or OUD. So it's an interesting drug, buprenorphine. It is called a partial agonist, a partial opioid agonist. So for those of you that are non-medical like me, I'm a psychologist by training, but what an agonist in this term is an agent that interacts with a receptor in the body and essentially turns it on. So an agonist, when we're talking about opioids, attaches to those opioid receptors and activates them in the same way that something like heroin or oxycodone would. So when you're talking about a drug like methadone, methadone is a full, long-acting agonist. And the idea is part of the reason why it is so tightly regulated. You get, with methadone, you try to get a large enough dose to reduce cravings, but not so large, certainly not so large to induce overdose, but trying to stay away from euphoric effects. Buprenorphine is interesting is that it's a partial agonist. So it activates those receptors, but only to a certain point. So what it does is it turns them on enough that it prevents folks from going into withdrawal and reduces cravings. But for somebody who has developed a physiological dependence on opioids, it is not going to induce the euphoric effects that we associate with a full agonist opioid, so heroin, oxycodone, et cetera. It also has a ceiling effect. I guess that's sort of implied with the partial agonist. It also binds really tightly to the receptors. And so this is useful for folks that might have a bit of a slip up while they're in treatment. It kind of blocks the receptors from being able to interact with a full agonist opioid if the buprenorphine is on board. So it's a pretty cool drug, both in terms of treatment and in terms of some of the harm reduction. We know that primary care is a good candidate for doing this type of treatment. As I tried to illustrate on one of those earlier slides, we don't have a lot of methadone clinics in our area, but we do have a lot of primary care clinics. And we had the feeling when we were starting our district project that if we were able to build this treatment into primary care, it would be more accessible for our patients and would also be sustainable after disrupt was over, because it's care for which practitioners can be reimbursed. So there's just no reason that it can't continue even after explicit funding from the state dries up. We know from our review of the literature that buprenorphine treatment delivered from the context of primary care is effective. We also believe that primary care has sort of a good bedrock for framing opioid use disorder as a chronic health condition, which allows us more easily to take a low threshold or harm reduction approach. I'm going to talk more about harm reduction in some subsequent slides. When we talk about low threshold, we mean that it is easy for folks to get into and to stay into care. So it means that they don't have to go through a real long series of evaluations in order to be able to start getting their treatment. It means that it's really pretty difficult, not impossible, but it's pretty difficult to get kicked out of a primary care practice. It also, when it's in primary care, it allows us to be able to care for conditions that tend to coincide with opioid use disorder. So in primary care, we're used to looking at counseling and offering help with things like birth control. Can be pretty relevant if you're dealing with a person of childbearing age who is also struggling with OUD. We are able to screen for, refer to, and sometimes even treat things like hepatitis C. So it's a nice setting to be able to manage OUD for that reason. Up until, it sounds like, I was saying to Julia before we started, it looks like this could be changing very, very soon. This is kind of a surprising announcement that just came out last night. But over the years, in order to be able to treat opioid use disorder with buprenorphine in a primary care setting, clinicians who want to do this work have to do some additional training. They have to get something called a data waiver or an X license. So for physicians, this means getting some special designating training that takes 8 hours. For our advanced practice clinicians, our nurse practitioners, our physicians, I would be thrilled if people want to have a conversation or if there are questions about this work or our study, I'd be happy to try to answer them or engage in discussion.
Yeah, folks, we really do want your thoughts and questions about how to do this, how it works, how does James do this in his own practice, right? Like, how does this engage when the rubber hits the road?
Suppose I can open my chat box now. Oh, okay, that's all from before.
Shimla wants to know if Project Echo is only about buprenorphine. Great question.
Very good question. So if you're talking about our Echo, it was specifically aimed at using buprenorphine within primary care to treat addiction, treat opioid use disorder specifically. In order to do that care well, you have to have elements for discussion that are not just narrowly defined to talking about buprenorphine. So, we would talk about comorbidity of psychiatric disorders within OUD and buprenorphine. How do you deal with it? If your question is more broadly, then absolutely not. It is not only for buprenorphine or OUD. Like I touched on, it initially was done for hepatitis C. There are echoes out there for more broadly integrating behavioral health into primary care practices. So, I mean, you can do an echo on anything for which there is an audience and sort of a gap in knowledge. And you're looking to sort of move expertise from your hub out to your community providers. You could do an echo for anything that sort of fits that criteria.
Shimla wants to know if Echo is used in New York City also.
That's a good question. With our group, we didn't have anybody from New York City. We were focused in our area. I would imagine that there are echoes that have been offered to participants who are sitting in New York. And I just with all of the great researchers and clinicians that work and live in the New York City area, I would imagine that there have been some that have been offered. But I don't know specifically. I couldn't name off the top of my head an echo that was hosted out of New York City. But I would imagine that there is one.
Is there a way to integrate Project Echo with nursing schools? I wonder if that's something that you've considered.
I don't see why not. I mean, we invited nurses to come as non-clinician participants to our echoes, and we didn't track that thoroughly, but we really believe that for really any endeavor in primary care, if you don't have buy-in from nursing, it's just not going to go anywhere. And so we really wanted both in an interest of trying to make sure that the nurses had access to the information. We wanted them to participate, but sort of bigger picture, we just really wanted to sort of win hearts and minds. And so we really tried hard to get nurses on board. In terms of putting it into a nursing school, I mean, I don't see why you couldn't do one. And sort of related to our last question, the discussion would be, what is the echo going to be about? Like, what kind of information would be useful to go into a nursing school that would fit the needs of the participants? But I don't see any reason why it couldn't go in there.
Yeah, I think that's interesting. I see Scott Tyree on the call, and I'm curious, Scott, I don't know if you feel comfortable speaking up Oh, wait, sorry, Tiffany. Oh, I see several things. Sorry, I was going to ask a question. Danielle wants to know if the slides are going to be emailed to you. They will be. And Tiffany Gager wants to know if there's a specific referral process from one agency to another.
Let's see. So when we were doing, I didn't say this part. So part of doing this treatment, both sort of in maintaining the spirit of the law around doing treatment for OUD within primary care. So there was this statement out there that you can do this within primary care, but you can't, quote unquote, hold yourself out as a substance use disorder treatment provider. And so what does that mean? It's not super clear. One of the ways that we interpreted that is, okay, you can do this as part of the comprehensive care that you offer to your patients, but you can't just take patients for OUD treatment only while they are receiving their general primary care somewhere else. We also thought that this would make it more palatable for anxious clinicians at the beginning, where we're saying, look, we're only asking you to take care of patients that are already coming into your own clinic anyway. If somebody comes to you because they hear that they are doing this, that you're doing this work, and they want to have treatment for their OUD, by all means, we encourage you to take them on, but please take them on as a general primary care patient for whom treatment of OUD is part of the suite of services that you do. So, I mean, we've got referral systems that we will use to try to help people get all kinds of other services. We'll do referral systems sort of within Bassett for various subspecialty care needs, whether that is OBGYN care, whether that is mental health care. I mean, so this is a bit of an aside. So this is done alongside of my efforts to integrate behavioral health care writ large into primary care. So when folks come to receive care at my clinic or a handful of others, we've got mental health clinicians like myself that are right there in the clinic. But not everybody has that. So we've got processes to try to get people into mental health care if that's what's needed and we don't have somebody on site to do it. So I don't know if that answered your question or not, but I tried.
Yes, you did. I hope it's okay that I unmute myself.
Please do.
I just want to clarify and make sure my frazzled brain, because I haven't had any coffee, understood what you said.
Yeah.
So basically, in a nutshell, if someone I work with, I were to refer them to your services, they would have to basically also take over their primary care. So they'd have to also change primary care providers in order to retain your services, other than there's some other services that, okay, I'm sorry, my brain is scrambled. Other than, like you say, you do refer out to like OBGYN or something, but I'm a community health worker.
Yeah.
So basically what I'm hearing is that in order for them to work within your clinic, their PCP would have to be within your clinic.
You got it. They'd have to establish with a primary care clinician within one of our clinics that is doing this work.
Okay.
And then as part of the primary care that they were receiving, they absolutely would be eligible to receive buprenorphine for treatment of their OUD.
Perfect. That's exactly what I want to know. Thank you so much.
Oh, my pleasure. Thanks for asking.
We have about 10 minutes left. And I don't know if you touched on this.
Mind if I'm going to move this down while you tee up your question, Julia.
Okay.
I'm going to sit down in my chair here and
You're
take
done
my
tap dancing?
computer off my 5-foot stack of books.
Do it.
And all right, here we go.
Shimla had a question about orthopedic hospitals. Patients in orthopedic hospitals use pain medication almost like every 2 hours. Do you think ECHO can be applied to orthopedic hospitals? Is ECHO only related to addiction related cases?
It's not only related to addiction cases. I mean, if you had recognized experts in orthopedic care and they wanted to deliver, they wanted to sort of transfer that knowledge to community providers in orthopedics. That the application is malleable. It can be used for a variety of different topics. So yes, I think that could happen. You just have to have the right hub that has that specialty expertise.
Did you talk about very specifically what we're going to be doing this year as part of REACH?
Oh, did I?
Yeah.
Did I talk about it? What do you mean?
Yeah.
Or can I talk about it, or did I talk?
We didn't cover that, right?
No, I did not talk about that. No. So yeah, thanks. Thanks
The whole point.
bringing that up. Yeah, no, that's awesome. No, so this was just kind of summarize. This wasn't even covering all that we did with Echo. This was trying to sort of like break it down to like our first round of Echo. We've actually done 2 of these so far. So that was summarizing our first round of Echo. We then did a second round of Echo. We're looking at right now trying to do a second write-up of that. We tweaked it a little bit. We offered it a little bit less frequently, and the duration was a little bit shorter. So we did it twice per month instead of every week. And we did it for 75 minutes instead of 90 minutes. So we want to take a look and see if there are any detectable differences from offering it in that manner compared to what I just presented. Of course, there's going to be some confounding variables there. You've got kind of the early adopters versus the mid adopters, so on and so forth. But as Julia brings up, we are getting ready to kick off a third round of Echo as part of a HRSA-funded R-Core grant. Julia is often more in touch than me. I'm not going to be able to.
Rural Communities Opioid Response Program.
Thank you. But we're going to be doing this again. We're going to be collaborating again. We're lucky to have our partners from UMass on board again as partners. We're going to be kicking off. We're finalizing the dates right now, but I think probably either in March or in April, we're going to start another Echo for OUD. And it is going to be, at least as far as I'm concerned, it's going to be offered as widely as possible to try to help folks, either clinicians that are directly looking to prescribe buprenorphine for OUD or sort of allied clinicians who are interested in this work to kind of come into the fold and increase availability of treatment for patients in need.
Yeah, I think this is important to know that this is an ongoing project that we're developing, right? That we have funding for and deliverables for, but we're also building it kind of in the air, you know?
Building the plane as we fly.
Yes, exactly. But we want to make it as supportive as possible in the face of changing circumstances. Because this is fast moving stuff. And just in my efforts to recruit providers to prescribe bupe and to have a harm reduction mindset and framework, it's this like long process. It's kind of like getting people to through the states of change for substance use disorder, actually. You know, like you got a provider who like sees a problem, but doesn't necessarily know that there are these tools out there that might help. You introduce them to the tools a couple times, maybe they make sense, maybe they don't. You stay open and available for the next time it sort of comes up with them, and maybe eventually they're kind of committed to doing it in partnership with you and your community of support, but it's a process.
Absolutely, Julia. And I will not get into the weeds of this because we don't have time, but I did a presentation last year in the fall, right before COVID hit, with a colleague of mine who were both really interested in motivational interviewing. And we were talking about stages of change made me think about this. So kind of taking a motivational interviewing standpoint in terms of looking at organizations or systems, in terms of how do you get the most bang for your buck in amplifying an initiative like this. So how do you find people that have both influence and enthusiasm for a project like this, and find a way to amplify both while simultaneously finding a way to sort of damp down the message from people that are resistant. And it's cool for nerdy people like me to think about. But
it is cool, right? I mean, this is where like science and these professions intersect with activism and advocacy, right? Like we're part of these systems, particularly the healthcare system, that just they move so slowly, and yet they're built on trying to help folks. And also like other approaches do help people, not necessarily in the same way or as effectively, but you know, as there are many paths to recovery, I'm sure there are many paths to treatment.
oh yeah, 100%. I mean, so in other iterations of this study, I've spent time directly addressing 12-step programs and AA. And I think that, like so many things, people can get overly dogmatic and overly black and white when they think about and they talk about AA in both directions. You will see people that are way too critical of AA in a way that is completely unfair and really inappropriate. And on the other end, you will have people that insist on abstinence only and following these 12 steps is the only way to go. AA, if you look through the history, particularly as it pertains to treatment of alcohol use disorder, AA stepped up when medicine didn't. AA filled empty TB wards when medicine didn't know what to do with it, and stepped up and did something from patients when medicine was twiddling their thumbs. And so those of us that are really into research and data and get critical of AA for their inability to, it's anonymous. And so again, it's hard for them to report on patient level data. And sometimes, yes, they, like all of us, can become a little bit overly dogmatic. But AA has helped millions of people over the years, and it is absolutely a helpful approach for many people.
Yeah, absolutely. Yes, right. Abstinence is a helpful approach for folks. You know,
If you can get there, that
yeah,
wonderful. We love it.
really.
Go for it.
Yeah, and that like I spend so much time like, you know, talking up harm reduction and medication assisted therapy that I do sometimes not say like AA saved my dad's life, right? Like my dad was an alcoholic. AA was the gospel growing up in my house, and I totally think it worked for him really well. So it's
Well,
a process for me to even accept that there are other ways of doing it.
just here, I lost it here, but just to sort of emphasize this point, remember this slide here. I think you guys are seeing my slide. Abstinence fits within harm reduction, right?
Right.
Harm reduction is a spectrum. And so if you move from moderation to abstinence, that is not inconsistent with a harm reduction approach. It is just one point on the spectrum. So I don't think it's not difficult at all to have a harm reduction paradigm that makes space for abstinence. The problem comes when we get too black and white, where we think about it as abstinence or nothing, and anything short of abstinence is worthless. That's, I think, where the problem comes in.
Yeah, right. It's not a binary. It's not an either or. It's not a pick a side. We're not at war. This is a part of a larger ecosystem of how we help people and help each other. James, thank you so much. Thanks to everybody who's here, listening and engaging. Shimla is saying that slide is really helpful. That slide is really helpful for me too. Again, I'll send these out this afternoon. And I think, James, is your contact information on the PowerPoint presentation?
I mean, I don't think it has, but if you want to email me, it's really easy.
I'll include your email.
Yeah, james.anderson@bassett.org.
I'll put james.anderson@Bassett with 2 T's.
Yep.
It's in the chat.
And since it's been called out as a wonderful slide, I will agree. I want to give full credit to that slide. So this is I've done various iterations of this presentation for different groups. That slide was created by one of my fantastic co-authors on our paper that we're looking to get published Oh gosh, now she recently got married and her name changed. So it's Amber Cahill now. Used to be Amber Hewitt, but that is her slide, and I love it. And we've used it in presentations before, so I put it in here. So I agree, it's a great slide. I use it, I explain it, but I didn't make it. That was Amber.
Yeah, that's good. It takes an ecosystem. All right, folks, we are at time. Thank you so much. Thank you to James. I love working with you. It's really a pleasure. Thanks to everybody who attended. I've dropped the links to the evaluation form and the certificate of attendance in the chat box. This session will go up today or tomorrow, and it's a YouTube video, maybe tomorrow. I will be emailing out the updated PowerPoints and James's email to everybody who registered for this session. Thank you so much. Don't forget, there's our last session of the week is at 3 o'clock today. It is a play about addiction. It is a panel afterwards as well. You will, I promise, see the tension inherent in the discourse about addiction portrayed in the play and some of the assumptions the characters make. And then there will be a critique by different panelists. All this stuff is right in the mix. So keep that slide in mind about how it's all on the spectrum. All right, folks. Thanks,
Julia. Thanks for coming, everybody. It was a pleasure, and have a great weekend. And don't forget about our other pandemic out there. Stay safe and get vaccinated, please.
Yes, absolutely.
Yeah.
Have a great one.
Bye, everybody.